So some of what we are going to discuss now, have been mentioned early in the morning. And what we want to know is your practical experience in regards to either testing for CoQ10, magnesium, copper, and other micronutrients. And to what extent do you use those products in your practice?
Probably more profoundly than any of the other ones would be magnesium. I think that if we looked at all of the deficiencies known to mankind and even all of the disease processes, magnesium deficiency would probably be paramount. I think if you consider magnesium to be one of the foremost cations in the human body, that the lack thereof and to what degree that extends, and I think within individuals and amongst individuals we can get into laboratory discussions about what are the normal levels and quote-unquote normal. And I think those quote-unquote normal levels vary significantly amongst patients. Who needs X amount of what is a very big factor. In answer partially to your question, I think that it's an everyday issue with me as far as my patients are concerned. The application of magnesium, there's a handout they're going to probably pass around with some IV protocols that are just basic stuff that we use at the clinic, but you'll see that magnesium is used very frequently. I mentioned mag sulfate in there, but we use other ones, mag citrate. I think you can get away with a lot of magnesium intervention for some very common problems. Here we're talking about heart disease. We all would be silly if we ignored the fact that the heart requires a significant amount of magnesium, and the application thereof can really make a tremendous difference as far as some of those things are concerned, particularly arrhythmias. I have numerous patients with diagnoses of atrial fibrillation or other various and sundry SATs, practically any arrhythmias that I could get somebody in and give them 4 or 5, 6. I've given 10,000 milligrams, 10 grams of magnesium sulfate intravenously.
Over how long?
Hour and a half, 2 hours with vitamin C. I'll apply them with 25, 50,000 milligrams of vitamin C in an IV bag of D5, or sterile water, actually. And you can apply some other things, particularly magnesium in conjunction with vitamin B6. We can treat a lot of very common problems with mag and B6. Hypertension, we're talking about heart disease today, or heart issues today, but hypertension, very, very simple, just to take somebody with a benign, quote-unquote, if you can say benign hypertension issue, and treat them with 400 milligrams of magnesium oxide twice a day with 100 mg of B6 BID as well, and have that essentially eradicated without the talk of any prescription medication. But my arrhythmia patients come in very frequently.
And so does the arrhythmia settles down?
Resolve, yeah. I have a couple of AFib patients that come in 2 or 3 times a year.
Okay, that was the question. How often do you do that?
As necessary. I could give it to them 5 days a week, but intravenously is not going to be obviously the same as you couldn't take 10 grams. Hello, mag citrate. See you later.
Bring plain toilet paper.
Right, please.
So, Dr. Mason, do you measure CoQ10, magnesium, copper, and other nutrients? Do you use it in your practice? And how do you use it preferentially?
We do on patients that can and will afford it. That's one of the drawbacks. I look at serum, CoQ10 for the most part. For the other nutrient trace elements, I kind of prefer erythrocyte, packed erythrocyte elemental analysis. These primarily are intracellularly accumulated. It's worthless to look at magnesium levels in serum. I mean, if they've got serious problems in their serum magnesium level, they're probably going to be in the ICU.
So, as a curiosity, how much does it cost to test CoQ10 levels here in the States?
We're paying about $150.
$150
through LabCorp, and it's blue boxed which means it's not an approved, test, so it's not going to be paid for by any insurance companies. And I know there's plenty of other suppliers maybe competitive with that. We've used variably doctors' data, Genova Laboratories red cell analysis, and as Chuck pointed out, magnesium is so critical that even in conventional medicine, I think we've forgotten about it. The
But
use of
we truly
magnesium.
forgot about it in
Yeah,
conventional
the use
medicine.
of unless you're specializing in something like OB-GYN, the use of mag sulfate in treating preeclampsia. I worked with a cardiology fellow in the ER that was moonlighting, and he was working with magnesium sulfate in MI, immediate post-MI, asthmatics, status asthmaticus. So even conventional medicine was working along the areas of using magnesium, and all of a sudden it just kind of like disappears, almost from the pharmacy. You can't get it.
And so how about, do you use any D-ribose and L-carnitine, taurine? Do you have a mixture that you put together?
I have been using purified D-ribose. The product that I'm using is from Douglas Laboratories now, called Corvalent Bioenergetics. I guess holds a patent on its production, not the chemical itself. Kind of expensive, but there's no doubt there's dozens and dozens of well-done, double-blind, experimental controlled experiments that show that you can drop somebody's New York heart failure classification a full step. You can take somebody 3, turn them 2, take 1, turn them 0. So all of my congestive heart failure patients are encouraged to be on fairly large doses of ribose.
So what dosage would that be, like 5 grams,
I'm
4 times a day?
recommending 5 grams 3 times a day. More, I don't think you're going to hurt them. I can put them on 10 3 times a day for somebody that's class 3. I'm using it in fibromyalgia as well. There's been some studies showing fibromyalgia benefits. And you always want to throw the magnesium in there with it too. I do that separately so I can kind of control magnesium levels. And certainly ribose has been included into many of the multi-nutrient products. I see it in several different products. And its benefits in improving ATP production is, apparently it's great benefit, but let's not forget it's also the backbone for DNA and RNA.
Yes.
And a rather difficult molecule to extract from the diet because the primary source is in the DNA of the living creatures we eat. And DNA is a complex molecule, requires some rather laborious enzymatic effect to tear it apart. It's not just like snipping up a carbohydrate or a protein. It's a little harder to get it out of DNA. There are other sources of ribose in the starches of various types, but the purified form is readily absorbed. There are some experiments. I talked to some of the people that work with bioenergetics, and they're working on trying to develop safe intravenous forms.
Oh. Dr. Mary, do you use any, let's say, D-ribose and L-carnitine?
I do a lot. As a matter of fact, carnitine, arginine, magnesium, hawthorn berry as a substitute for digoxin in all the heart failure patients, along with magnesium B6 and coenzyme Q10. But again, here, and even myself, I plagiarized one of Linus Pauling's. If you look at my business card, it's orthomolecular medicine for the new millennium. What we're talking about here is basically Krebs cycle function. If you can't get that straight, then you don't have ATP. And 0 ATP equals death. Optimal ATP equals optimal health. None of us live there. Nobody. We try to approach it, but we're not going to get there. But coenzyme Q10, we talk about testing. In a lot of the things that we do, there's been discussion I've noticed all morning about, how much does this test cost and that test cost? Well, it's kind of like thyroid. I got a ton of thyroid patients, a ton. And to answer some of those questions that Robin presented, I think it's upwards of 45% of the female population is hypothyroid, undiagnosed, because they're so busy looking at the useless TSH. My argument to all my patients is, it's dirt cheap, it's not going to hurt you, it might change your life, it's organic or natural, and try it for a month or two. And inevitably, they all come back a month later and go, oh my
So
God,
I
it's a
guess you are
miracle.
talking about about Armour thyroid.
Armour is what I prefer to use,
Okay.
until they
My
change the
question
formula,
was,
yeah.
my question now was like L-carnitine. I just need to follow.
Oh, the
format in
carnitine,
here.
of course. Yes, 500 BID.
So the next question that a patient will ask is, for how long do I use this?
For what condition?
Well, let's say congestive heart failure. You move the patient down one category. They are now class 2
Well,
or
of course,
class 1.
Cranked it.
My patients now identified that way, they're being treated with ribose supportively. They're undergoing metal detoxification, chelation therapy. We're detoxifying them in any way we can. We're trying to improve their circulation and myocardial toxicity. There's plenty of what we think is ischemic cardiomyopathy out there, is partially idiopathic toxic cardiomyopathy, and we need to look at it in a more global fashion. So I'm always trying to improve their circulatory component to their heart, as well as trying to detoxify and get their myocardium back to health. It's a pretty well demonstrated fact that our stem cells can regenerate
We're
our
going to have a
myocardium.
topic on stem cells. So the next question I have is that, do you use vitamin E? Do we go back to the old antioxidants, use vitamin E, and which type of vitamin E do you use? And what dosage?
I use mixed tocopherols. I have a specific product I've been using for years and very happy with. I do warn patients against using the DL form that is quite inexpensive. There's clear evidence that the mixed forms are necessary for the benefits of vitamin E. I usually use 800 milligrams daily. If they have any...
Eunice.
yes, excuse me, international units. I will back that off if we see some easy bruising, evidence that they're getting some, little too thin of blood. But I've not seen that too often.
Really?
And then, Chuck, do you use any folic acid, or is it folic acid bad or good for the heart?
No, tremendous benefit. It's one of those things, again, that's very inexpensive and easy to supplement. Testing the conditions. I don't know why we have such a big problem with homocysteine issues nowadays. Just treat them. I mean, give them the B12 and the folate. Stop it. Give them the stuff.
And we just heard about, I guess, if you guys went for lunch, we just heard about L-arginine. Or do you use L-arginine in your practice, and do you?
The best natural Viagra ever.
Okay.
Yeah.
And to
There's
which
no doubt.
dosages do you use? What frequency do you use L-arginine?
Grams.
Yeah, I'm recommending at least 5 grams, 10 grams twice a day. There will be patients that require more. The problem with L-arginine is that it has a short half-life taken orally. And to get 5 grams, you got your big handful of pills. So in order for it to be effective at treating hypertension, other problems, we've got a pharmacokinetic problem. And some of the products have been developed use the nice little trick of using L-citrulline, which is the byproduct of turning L-arginine into nitric oxide, the endothelial relaxing factor, becomes citrulline. Citrulline can be turned back into L-arginine. So they found a nice little biochemical loop to maintain levels of L-arginine. There's a lot of those products out there. And certainly other combinations of amino acids and cofactors are necessary too. But there's no doubt that L-arginine is a vasodilatory amino acid, if that enzyme's working properly.
Dr. Jaffe?
If you're using those levels of L-arginine, are you ever concerned about imbalancing the lysine pool with an increased risk of DNA virus?
Possibly. Possibly.
Also easy
Because
to
you're
supplement.
generating citrulline, and it can be degraded into lysine.
You know, you can get L-arginine from some sources as a powder, very, very cheap, you know, instead of the pills.
Yeah, it's not an expensive chemical. And
Any
most of them
other,
are
any other
synthesized.
question from the audience in regards to magnesium, CoQ10, the ribose?
I want to make a comment on magnesium. There's several issues, but one of the important thing I will recommend is to test for the magnesium status. The best testers do magnesium load tests. We do all the time in our office. If anyone needs the protocol, just send me an email. We will do that. And that is more sensitive than anything else we have seen.
Yeah. Before we leave L-arginine, I'd like to make mention of a relatively recently studied direct inhibitor of nitric oxide synthetase called asymmetric dimethyl arginine. It is made from arginine by enzymes that we don't know how and why they're controlled, but it's clear oxidative stress, hypoxia, tissue damage of all sorts. You know, when we say the word oxidative stress, that covers a whole lot of, physiological situations. But if the levels of ADMA are high, we can apparently overcome the inhibitory effects of ADMA by increasing the amount of L-arginine. So a lot of laboratories have offered L-arginine and ADMA assays on serum, blood, and a ratio of the two. The idea being to try to overcome the inhibitory effects of ADMA by adding more L-arginine. As like Dr. Jaffe pointed out, is there going to be a point where you're going to be putting in so much L-arginine, generating so much citrulline, generating so much lysine that now you're tipping the scales towards another immunological event? The other important thing is we know that there are at least 3 identified types of nitric oxide synthetase. The first one discovered was in the endothelia. Now we know that there's a neuronal form found in glial cells, in neurons, and an inducible form that appears in primarily the immune system, but other tissues as well. So now that adds to the complexity of it. What are we getting out of L-arginine? We're getting nitric oxide. What does nitric oxide do in the nervous system? What does it do in the immune system? So we're going to find contraindications to using certain amounts of L-arginine in certain circumstances. It has become fairly clear that one place it's contraindicated is in the acute post-myocardial infarct status. In that condition, the heart suffered hypoxic damage, and inducible forms of nitric oxide are being produced. And when we feed it L-arginine, we get reactive oxygen species. We get some possible worsening of tissue damage.
So is there a practical test to use to measure nitric oxide?
It was previously and still is.
And just a brief answer.
Measured by high-pressure liquid chromatography on serum. But in the last few years, they've developed enzyme-linked immunoassays. They're relatively simple to perform.
But the question, like, is there an office test that we can imply or use?
There's a test that's just been approved of for use in the United States. It's called the ADMA test. They have some literature out at one of the vendors here. A small sample of dried blood is placed on spots on a card, and at this time right now it's going over to Europe. But there's a California heart clinic that is now being set up to run that in the United States, and they're asking me if I want to maybe try to set up a lab on the West Coast side. It's a relatively simple, immunoassay. You treat with the antibodies, you develop the enzyme reaction, you read it in a plate
But there
reader
is not
and
an
bang.
in-office testing that we can...
Not one you'd like a dipstick for
No.
urine.
Yeah, that was my question. Does anybody knows of any testing for...
I'm trying to think of the scientist who developed it. The and I just heard him lecture. And they developed a saliva test for nitric oxide, and it's being sold by complementary prescriptions. So you can use that in your office.
Yeah. Nitric oxide, we have to be very, very careful about. It's a very volatile gas. There are some devices for exhaled nitric oxide. They're being used to evaluate a pulmonary disease, particularly asthma, and some of the interventions to try to reduce nitric or increase nitric oxide in the pulmonary system, producing better vasodilatation and improvement in pulmonary hypertension.
Thank you very much. So I was looking at the program, and I thought that maybe we should cover the Courage and the OAT trials, and then the intravenous EDTA, and after that goes into how to manage the difficult problems like atrial fibrillation and CHF. I don't know if Dr. Bernhoff and Dr. Carter are in agreement with that, to use it at the end. Because that way we can look at the IV protocols and then adjust and make changes related to these conditions. So I'd like to thank Dr. Mason and Dr. Mary. And
Thank you.